So welcome everybody to Rush Renal Biopsy Conference for February 19th, 2026. I have an announcement. Next slide.
Oh, oh my goodness. Thank you, Roger.
We have some music. I don't know if it's going to come out or not, but it's... So yeah, I mean, it's something else. Congratulations, Dick. And those are some of our fondest memories. There we are in Hawaii at
Yeah.
GlenCon being silly and that great meal at Mario's
Oh, yeah.
last fall.
Mario
So
really knows how to cook beef.
yeah, he sure
Yeah.
does. So
And he chose the right cook, the right temperature and the right meat too.
it was unbelievable. I still
Yeah.
think about it.
Yeah.
Uh, Pravir, you want to walk us through through your case?
Let me share the file here for the PDF for people.
I should say we have nothing to disclose, and patient confidentiality has been preserved.
Oh, that should be the case. Let's make sure. Yep. Okay, perfect. So in today's case, we have a 40-year-old Hispanic man who presents with severe swelling of his legs and abdomen. So he was really at his usual state of health, at baseline until about 2 months ago when he first started noticing lower extremity bilateral swelling that got so bad it started to progress up to his scrotum and abdomen. Before all this had happened, about a month before he noticed the swelling, he had experienced a flare of his psoriatic arthritis, which was his main medical history. And during this time, he had severe arthralgias like he's had before, and a worsening skin rash. He was started on a new medication, roflumilast, which again I can't pronounce. It's a selective PDE4 inhibitor. He hadn't been on that before. This was new. He also received a short course of steroids, which was ineffective. He started taking ibuprofen, and he calculated based on how many pills he told us in the bottle that it came out to about 1.2 grams of ibuprofen daily because none of this was working for his pain. His swelling continued to get worse, so he was seen by his primary care doctor and was started on Lasix 20 milligrams. That again provided no relief. He had no shortness of breath, no hematuria, no recent illnesses that preceded this flare. And outside of the two medications listed above, he had started nothing else new prescribed or over the counter. Because he wasn't getting better, he presented to the emergency room where we first saw him. On arrival, his creatinine was 1.1. Going back through the records, is very near his baseline, which had ranged from 0.8 to 1. His serum albumin was 1. His baseline previously was normal at 4. We obtained a urinalysis that showed 4 plus protein on dipstick, 1 plus blood, had only 1 RBC on microscopic analysis. His UPC ratio was 13.4 grams per gram, and we added on a urine albumin to creatinine ratio that, because of the number was above the detection of laboratory, we couldn't actually quantitate how much of that was actually albumin, but presumably predominantly albumin based on that. We got CT imaging that showed diffuse diffuse anasarca, had no hydronephrosis, he had no renal masses, and that's kind of what we had. In terms of his medical history, he had psoriasis, as I mentioned, obesity, and obstructive sleep apnea. He was on ibuprofen, 1.2 grams daily, leading up to admission. He was still taking it at the time that we saw him. He had stopped the new PD4E inhibitor for his arthritis since it was not working. He had recently started a Lasix 20, which he was still taking. And then he was taking an ointment. It was prescribed just recently after this flare had started. And he was also on Manjaro, which is not new for his obesity. Surgical history, none. He had no family history of autoimmune disease, did not smoke, no other drug use, had very occasional alcohol use, but not regularly. On exam, his blood pressure was 134/70. His BMI was 46.5. He was overall, in good spirits, not in respiratory distress. The major thing to note on exam was he has a chronic psoriasis rash, which had improved a little, but still present. And then he had 3 plus pitting edema all the way up to his abdomen. And it was quite remarkable. His labs, in terms of pertinent findings, his albumin was 0.9 when we had repeated it. His calcium was 10.6. Creatinine was 1.0. His LFTs, unremarkable. His iron sat was 31% with a ferritin 186. His hemoglobin was 12.5. His lipid panel is listed there, cholesterol 293. Triglycerides 191. We did a serological workup. His ANA was negative. Anti-double-stranded DNA was unremarkable. C3, C4, those are both normal for our labs. ANCA was negative. Rheumatoid factor was less than 13, again, negative/normal. HIV, hepatitis were all negative. We did get an anti-PLA2R antibody back that was negative. We checked SPEP and UPEP. Both did not show evidence of any monoclonal gammopathy. His kappa lambda ratio was 1.24 with the absolute levels of kappa and lambda listed there. His UA, again, repeated again and showed 3+ protein on dipstick. Again, occult blood on the dipstick with only one RBC that was seen under the microscope. And his repeat UPC ratio was, again, 13.4. And the UAC, again, we could not get an exact value as it was above the detection of the lab. Based on this, a kidney biopsy was recommended and performed.
Any questions for Dr. Baxi? Great. Let's see what people think. So what do you think this patient has? Membranous glomerulonephritis, a podocytopathy, minimal change disease with acute interstitial nephritis, obesity-related GN, or other being something rare or not included in 1, 2, 3, 4. As usual, we can't see who's voting on anything, so don't be shy. I like to get a good representation from our audience. Let's get a few more votes in. That's probably representative. Stop it. So as you can see, the top vote is a podocytopathy. Second is MC minimal change with interstitial nephritis. We've got 5 people that think it's rare, 3 people think it's obesity-related, and 3 think it's membranous. So the 2 lowest are obesity-related GN and membranous. Let me hand it over to Dr. Gashti, and I want you to go through each of these and tell me what you think.
So it seems like this gentleman, Hispanic, 40-year-old Hispanic male who has this background of psoriasis, but now with a recent flare of psoriatic arthritis, who comes in with, based on this history, it appears pretty sudden onset, and of edema, and he has nephrotic syndrome, albumin of 1 and 13 grams of proteinuria. So my first thought is, based on the very low serum albumin, history of NSAID use, high cholesterol, although I would have expected the cholesterol to be a little bit higher, but I'm not being too picky here. Minimal change seems, or a podocytopathy without AIN, I suppose, would be high on my differential. There are a slathering of different glomerulonephritis associated with psoriatic arthritis. Both membranous, IgA, and minimal change have all been described. So it could be that, but it seems like a recent flare may have precipitated this nephrotic syndrome. So I feel like the podocytopathy that's triggered may still make sense and fit. So my first choice would be number 2. Membranous is possible. We have a negative PLA2R, so not a primary membranous or not a PLA2R positive membranous, but it could be one of the other antigens, or it could be related to the arthritis. So that's not ruled out by any means. So that's on the differential, but I think based on how low the albumin is and how quickly this patient presented with nephrotic syndrome, I'm going to push that down a little bit below minimal change disease or podocytopathy. AIN is always possible, but I feel like the patient has a baseline normal kidney function. Doesn't have much pyuria, hematuria. Although it can be seen without those presentations, I feel like maybe that's less likely to have AIN. So 3 is less likely. Obesity-related glomerulopathy does not present this way. It's not a sudden onset of nephrotic syndrome. In fact, most of the time they have proteinuria, but not really nephrotic syndrome. So maybe he has that in the background, but that's not the cause of the current presentation of the nephrotic syndrome. And as being mentioned in the chat, a lot of the drugs, the GLPs causing an antinephrin antibody causing, again, on histology would be a podocytopathy. That's another thing. And then amyloid has also been mentioned, chronic inflammatory diseases causing secondary amyloidosis. So that's pretty much going through the 5. My number 1 would be a number 2, podocytopathy.
It's interesting. We don't have the ability to compare the albuminuria to the proteinuria because it's above detection levels. But we do talk at this conference a lot about, with minimal change of disease being more selective proteinuria and being a much higher percentage of albuminuria than, and I don't know what number it is that you lose the ability to detect.
Over 90%, I feel over, the albumin to creatinine of albumin AC ratio being 90% of the total protein, I think is very highly.
Yeah, what I was saying is at what level of albuminuria does the lab just say I can't measure it anymore? I think it's pretty low. I think it's 5,000 or 6,000. I don't think, so who knows if he's 6,000 or 11,000, 90% of what his proteinuria is. We don't really know. It would be interesting, but I don't know if that's ever going to change. It's such an odd thing that that no one would really ever care specifically about knowing exactly what the albuminuria is, except compared to the proteinuria, except maybe in this one question, which is probably moot too, because we're going to biopsy. But we look at clues and we make decisions and we go on. Bill, what do you think's going on?
Yeah, I really don't have that much to add to what Casey said. I think the only one that's not going to be is 4 because it really just doesn't present there. Just like Casey said, that could be there in the background, and if it is not responsible for his clinical presentation now, which is an abrupt onset of nephrotic syndrome. And so when I hear that abrupt onset of nephrotic syndrome, I'm usually thinking podocytopathy, and NSAIDs probably are the implicating factor there. They can also cause one of the membranous ones that I think has been recently discovered, which was the PCSK6 or something. I may have that wrong. I also don't know anything about this PDE4 inhibitor. I would have to Google that and see if that, or look it up and see if that causes any glomerular disease. I really don't know. I'm just not too familiar with that. There's some chat questions also about GLP-1 causing nephrotic syndrome, and I wasn't really aware of that either. So if that's the case, I'll be educated today. Just like
I think the drug that he's on is actually anti-TNF. So I feel like that's not only not the cause, in fact, I think in some cases may even be protective. So I'm not really sure if we can blame that drug, but
actually PDE4 inhibitor in animal studies, actually it's a kidney protective.
Okay, yeah, I think that's also what Dr. Gasher was kind of saying. It's unlikely. So yeah, great.
And Prevere did look it up, and there was no association. So
a little history comment might be appropriate here. In the days before biologics, psoriasis was treated with ammoniated mercury ointment. I know this patient doesn't have a history of ammoniated mercury ointment exposure, but it's commonly used over the counter. And I must say, I would ask him, did you use any over the counter ointment prior to using the steroid ointment that was prescribed for you?
No, no, and he did not.
Well, I just, whenever I see psoriasis and nephrotic syndrome, my mind clicks on membranous due to mercury. And of course, this will not be detected by an anti-PLA2R. You need an anti-NEL, and that is not commercially available. You can get it in some labs, but it's not an easily obtained. But the biopsy will give you the answer. So I think the discussion of a diffuse podocytopathy is highly appropriate, and I would agree that's not number 1, but I would keep membranous in mind.
Mario, what's your number 1?
Number 2.
Number 2, podocytopathy. Arun?
Yeah, I favor podocytopathy. The only point which I wanted to make was that sudden onset abrupt nephrosis, particularly from a membranous standpoint, is more common with NEL1. We've seen, some inciting agent, but I don't see a clear inciter for an L1 until Dr. Classic mentioned about the mercurated cream. I don't know if PCSK6 presents with sudden onset abrupt nephrosis. So the sudden onset of abrupt nephrosis with a normal cholesterol panel is somewhat swaying me away from a podocytopathy, but definitely podocytopathy is my number one. And if it's a membranous, I think it'll be an L1. I'll put that as my differential.
All right, next slide. So did we miss anything? Well, I didn't think of course, I always underestimate our audience, and I didn't know that people would be so aware of the GLP-1 association. But, if we talk about membranous, it's pretty much been brought up, but membranous is associated with psoriasis, non-steroidals, or other non-PLA2R antibodies. A podocytopathy, if it is, could be idiopathic, it could be non-steroidal related, or GLP-1 has been brought up. And the interesting thing about the GLP-1 is that those, and I'll go over this a little bit later. I'm going over everything, so I'm not giving anything away. But the GLP-1 is the anti-nephrin dusting, and I don't know that we have the sensitivity or we've ever had that come back positive on anything that's in any of our cases so far. It's maybe it's a sensitivity we don't have so far. There's, of course, minimal change with AIN, which is non-steroidal induced. That tends to have a little bit of renal failure and pyuria, as was brought up by Casey or Bill. Obesity-related glomerulopathy really doesn't fit. And, of course, there's always something else. That, was interesting is that in the voting, it was pretty equal across everything. I mean, podocytopathy clearly won, but everything else had, 4 or 5 votes. So that's why we do biopsies, as the ape is showing us as he's pondering the diagnosis here. So a biopsy was done, and let's spin the wheel and see who reads it. Pull the wheel up.
Nice picture.
All right, is it live? Oh, it's live, okay.
Is that picture from Robert Clark?
I'm not sure, I don't think so. I think that was off the internet. I don't know where we got it.
No,
I had a first one, and people were offended by it because it went too much into the medulla. So we found this other one.
This one actually, I was Karen Griffin a fellow at Rush, Roger?
Yeah, she was.
Yeah, so I think that Karen Griffin had this in the Journal of Critical Illness in 1992. And that's where I got this picture in my background. Yo, there we go.
Fantastic.
Yeah, I think she was the lead author, and she was the one. I don't know if she drew it, but she's the one that published this.
Well, stay on, Bill, because you get to read the biopsy.
Oh,
the wheel picked you.
Give me a second here.
I'm gonna somehow make it minimal change because that was my number one, even if it wasn't.
Go ahead and click on the screen. Yep,
Thank
you're controlling it.
here. Okay, here we go. Okay, here we have a low power. Usually I say trichrome, but I don't see much blue here. Okay, so there is some light blue standing here. So I would just say that, not surprising, there's not much blue standing here, and there's no fibrosis, no scarring. Sometimes you can see blue with edema, which you might see with its significant nephrosis, but I don't really see it here either. The glomeruli, I'll comment on at a higher power. We'll go to that higher power now, where we see a H&E, and here's glomerulus in the center with some. It's interesting that there's maybe some red cells in Bowman space, but that's sort of unexplained. But this glomerulus actually H&E looks relatively normal. The capillary walls appear thin and delicate. Maybe this is a little thick, or maybe this one's a little thick, but I think that's an overcall. The mesangium seems normal. Here's the hilum. This all looks pretty normal. The tubules interstitium also look normal. I don't see any blood vessels, but no real abnormalities there. And David, correct me if I'm misspeaking, please.
No, you're doing great.
Here's another high power PAS. This obesity thing was in the differential, and we'll see if we get a measurement or if we'll rely on David's keen eye to see if there's large glomeruli. Here also, this looks pretty normal. I don't see any adhesions. I see thin capillary walls on this PAS. No mesangial expansion, which you would maybe see on a PAS. Again, tubules look normal. This is maybe a distal tubule here
distal tubule.
because it doesn't have the brush border, and we have proximal tubule here with a brush border and some proximal ones up there. Okay, so just because this is bigger than screen, unless David blew it up, I'm going to say that it's going to be glomerulomegaly, but we'll, again, wait for David's final read on that. But maybe he just did it higher power to look closely at the basement membranes, which, of course, the Jones highlights. These have nice, smooth borders. This is even maybe a little bit of an en-face section. I don't see any holes. Looking for spikes and holes, and I don't really see any. Looks pretty normal to me. So I'll still call it normal. Here is back to PAS, and I think so.
H&E.
Sorry, H&E. And here's a glomerulus in the bottom left half here.
Yeah, and then to the right, there's some interstitial nephritis.
Okay, yeah, so here's a lymphocytic infiltrate. And considering the glomeruli are all normal, this is, out of proportion to any, it's not like in an area of a diseased or obsolescent glomeruli. And so therefore it looks like a primary interstitial nephritis. I'm also looking for eosinophils, which I do not see.
We'll go higher power. It'd be hard to see him on this power.
Gotcha. We would need Mario's eagle eye for that.
Yeah.
I've got, maybe there's an EO here.
Yeah.
And but most of these are lymphocytic.
Yep.
And there's a little bit of tubular destruction here too, along with that interstitial nephritis. Probably a granular cast here, I would imagine.
Yep.
Or maybe even a white cell cast because there's some nuclei there. Oh boy, so much for no no spikes and holes. This is a granular pattern here. It's funny though because it almost looks contiguous, but I'm going to still saying that it's just some long granular pattern. And sorry, my camera's covering it. I imagine this is IgG.
Yep.
Okay. Sorry, my camera's covering the which one it is. Okay, so we have granular IgG in the basement membranes, and we have an interstitial nephritis. And now here's our EM. And not surprising, in our glomerular basement membrane here are podocytes on the outside, our fenestrated endothelial cell here on the inside. But what we are seeing here is these electron-dense deposits in the glomerular basement membrane, which again would be consistent with membranous. There's some here too. There's some here, sort of subepithelial. And yeah, really they're all over the place. Subepithelial, immune deposits. And then if we look at the podocytes, I don't really see any slit pore diaphragms. Maybe in this little section here, there's some preservation, but we also look at, and it seems to be that they're diffusely effaced.
No, any mesangial?
Oh yeah, great point. Especially if we have a PLA2R negative membranous, we may be thinking about other types of membranous patterns. And if there's mesangial deposits, we may lean in a little bit more towards lupus. I think this might be a mesangial reflection area. I don't really see any deposits there. I think this is just kind of
mesangial cell there. Yeah.
Yeah. Okay. Good. I like to call it schmutz, but you call it yourself your own thing. David.
Yeah.
Can I ask you, a question? This patient has a false negative silver stain with EM showing striking spikes. How do you explain the fact that we can't really detect spikes when they're so evident by EM?
Yeah, I can't explain that. Oftentimes we see well-formed spikes and the EM looks like this, and then in this case, it doesn't make any sense to me. I can't. I even see little spikes coming off the GBM in areas. So
like here,
I
maybe.
don't know.
Yeah, usually it's basement membrane that would go around the spikes that would then cause the black stain of the silver to be positive. But I don't know, maybe it's just too early for GBM to grow around it. or that's probably a lame explanation.
Well, that would be the holes. I mean,
But the
Yeah,
GBM
then
has
there'd be
already
holes.
grown around
Yes.
it. Yeah.
Yeah, then there'd be
yeah,
a
the
lot of
spikes
holes.
are there. So, David, I think you've answered it already, but when Bill was saying that the light looked normal, sometimes you've been able to just take a light and call it membranous on the light alone. Were you able to see anything, or you really didn't see anything on light that thought that
On the first picture, going back, the GBM is a little thickened on H&E, but here on the silver stain, I
Sorry.
can't make out any spikes or holes.
okay.
It raises, David, it raises the possibility, but I've never seen any studies that the spike basement membrane material is silver negative, unlike the normal basement membrane, which is silver positive. And maybe if you have a slightly understained silver methenamine, that you might miss it, but we certainly did here. I mean, this lesion, I mean, this biopsy with silver methenamine is not compatible with stage 2 membranous at all.
But it doesn't seem understained because Bowman's is staining quite well here, and here we
Yeah.
have our GBM. So
You're right.
it's really hard to make. I
Okay.
mean, look at this area. There's well, maybe those are holes, but there's even in the en-face section, there's not really many holes.
So last week we had a membranous without proteinuria, and this week we have a membranous without spikes.
Yeah.
It's just another day of the rush renal biopsy happens.
Just another point of history. I have had referrals of patients like this with calling it anti-GBM disease. So it's possible for an unexperienced pathologist to look at this and say, aha, anti-GBM disease. But you're absolutely right, Bill. If you look carefully at high power, it's a diffuse granular with pseudo-linear pattern.
Yeah, here's some breaks or
Yeah.
areas where it's not staining.
Yeah.
So you kind of have to look closely to make sure that
Yeah.
true linear, as he's describing, would be this whole thing would be lighting up just like this one, I think. I don't see that much GBM, and I certainly haven't seen as much as Dr. Classic. But yeah, good. I'm glad I got that right. So again, another higher power EM, just seeing this the subepithelial spikes in here. And
Want to go back, Bill?
oh, yep, sorry. Yeesh.
Dr. Foot process effacement.
Yes. Yes. At the risk of alienating some of our audience here, I'm going to say that, yeah, they are diffusely effaced. I mean, this is a very, very small patch in high power, but even on the other one, I thought that, they were mostly effaced.
It's really impressive here.
Yeah. Yeah, I certainly don't see any slit pore diaphragms. So, well, next steps. I guess we can talk about it here, but we usually send them to Mayo for further staining. You could have PLA2R present in the biopsy and negative in the serum, and so that still was a possibility. So they should stain for PLA2R. They should stain for, I think, well, this is what Mayo does, right? Exostosin, thrombospondin, NEL1, and honestly, I didn't know that NEL did the rest of these, but it didn't detect these two, apparently.
Or Nell, if this was a mercury-containing cream or something, yeah.
So
And
want me to
you're right,
stop
the
there, and I'll let you take the screen back.
PCSK6 is the non-steroidal one that's more recently identified.
Right. So I would say right now, a PLA2R membranous, tiny bit of interstitial nephritis, but, most importantly, a lot of our differential was, it wasn't the PCK6 or PCSK6, and it wasn't L1.
And it wasn't PLA2R2.
Right.
Did not detect.
Yeah, it did not detect anything. It was so it's negative for everything that they're able to do, and they're
Yeah.
I think they've really grown in their in what they checked. Their mass spec used to be much more limited, but they check almost everything now.
Well,
So it's a antigen. It's an unknown membranous antigen antibody at this point, which I'm sure maybe at some point they'll just find more, and then maybe at some point we'll know. But so poll number 2: how would you treat this patient with non-PLA2R membranous nephropathy? rituximab alone, a cyclophosphamide-based protocol, or a combination of rituximab and cyclophosphamide, which is from the Mass General, we often call it the Niles protocol. 1 or 2 with a CNI, and or 6 months of RAS inhibition, then decide. Probably good representation. So interesting. Rituximab with or without cyclophosphamide seems to be the winner, and nobody wants to start with cyclophosphamide alone. And 1 or 2 of the CNI, it's kind of maybe gets a little confusing, but the idea there, of course, and I know Arun's a big fan of that, is to control the proteinuria while you're waiting for the drug to kick in. So the option number 4 is really probably option 1 and 3 or 1 and 2. So it's actually 1 and 2, but
this is a little bit obsolete because on February 15th, Roche announced the results of the Majesty trial, and obinutuzumab showed a fantastic result. And my guess is that within a period of few months, obinutuzumab is going to be the treatment of choice and not rituximab. But I would agree that right now, based on what we know,
it's also what we can get, to be honest. But yes, it's what we know. Yeah. That
you
would
have
be very
trouble
interesting.
getting obinu for membranous?
Yeah, we do. Yes.
And we have trouble getting Rituxan for lupus. So it has a lot to do with the FDA, and it's easier if it's been, approved by the FDA. It's a lot harder when it's not, but we can still get it. It just takes some extra time.
Yeah.
It's actually cheaper and easier to get, but it still requires a lot of insurance jumps. And I know
It's
that's
incredible to me that it's actually cheaper.
Yeah.
It's an amazing thing. Next slide. So Pravir, you want to tell us what you did?
Yeah, so this was, like I said, about, a little while ago, and about a year ago, coming up. So we did rituximab. So I did rituximab without steroids, without CNI, within ARB, optimizing his ARB, along with Eliquis, just given how bad how low his albumin was and how nephrotic he was. And we gave 2 doses, 1 gram each. I checked the CD19 after the first dose, before the second, actually after the second dose too. And they were both 0%. So CD19 counts for what it's worth. Were depressed. And his proteinuria, you can see here, really did not budge. And this is about coming up on 2 to 3 months at this point. And so at that point, he still had 14 grams of albumin, 14 grams of proteinuria. His albumin was still 0.9, and he was still edematous. He was on a diuretic, ARB, everything. So I decided to add on tacrolimus with the hope that maybe, the rituximab would slowly start to take effect. I know sometimes these can take a while with membranous, even though, they can respond quickly if it was something that he was taking, although the antigen testing from Mayo was all negative. If it was something that maybe for whatever reason the mass spec didn't take up and it was NSAID related or an ointment, the hope would be this would have responded a lot quicker, but it wasn't. So I added on tacrolimus, and sure enough, I was targeting 6 to 8, 7 to 9 levels around there, and it did come down. It did slowly come down to about 4.2, 4.5 grams as albumin came up. Highest it got was 1.9. And I said, okay, well, this is good. Let's give it some time. Now we're at about the 5 or 6 month mark, and I have not changed his tacrolimus level. And now it's back up to 10 grams, and his albumin is dropping again.
And we're 6 months out, and he's reconstituted his CD19.
Yeah. CD19 was checked again. Now it's 9.7%. This is his albumin along the same time. Like I said, the highest it got was 1.9. Now currently it's 1.9 still, but his proteinuria is back up to 10 grams. And his albumin, his tacrolimus levels have been, stable at the goal where we want it. 6 to 8 in that range.
So what would you do now? We're 6 months out. He really hasn't had a good response. Maybe the proteinuria came down a little bit with the TAC, but no evidence that there's a remission at this point. You have several options here. The rituximab did lower the CD19, but it's rebounding back. Should we redose with rituximab? Should we change to a cyclophosphamide-based protocol? Or the Niles protocol, which is rituximab now with cyclophosphamide. That's a couple months of oral cyclophosphamide. Or try to get OB. And I think that we're a little biased now from Dr. Glassick's statement earlier.
Of course, Roger, when you say the patient is not developing a remission, when you are saying that, a clinical remission. In this case, we don't know what the antibody is. Undoubtedly, he has an antibody in his circulation, but you just don't know what antigen it's directed to, and you have no assay to follow it. But if you did, you would have to base whether he's entering a remission or not based on what the antibody level is.
Absolutely. And if he were PLA2...
The clinical features are delayed by months or maybe even a year from the onset of the immunological remission. The problem with this case is you cannot measure an immunological remission.
Can I ask a question? How was the PLA2R antibody measured? What method was used?
It was the ELISA method.
That's right. So even though he's not a diabetic, this could be a false negative. So you have two other methods, as you know, indirect immunofluorescence and a Western blot.
Mm-hmm.
I personally will pursue those with a hope that perhaps this is in fact the PLA2R membranous.
Remember
the thought there would be, I guess, if we had that and the PLA2R was coming down, I would be a little more reassured, which would be good. But it's bounced back. So if the proteinuria has gone back up, you would.
But the mass spec was also negative.
The mass spec was negative. Yeah.
But the antigen can be negative. That doesn't mean that the antibody is negative. At any rate, that will be my thought. And my vote in terms of treatment will be number 3, because God help you if you try to get obinutuzumab to treat this patient.
So Mario, are you saying are you saying there's immunofluorescence negative and mass spec negative PLA2R membranous?
What I'm saying is that the antigen in the tissue can be negative, but the antibody can be positive.
Mario, not by
mass spectrometry was done, so with that rules out PLA2R.
Not by mass spec. The mass spec is the gold standard. If it's negative, it's not there.
What is not there? The antigen or the antibody or both?
The antigen is not there if mass spec is negative.
But you can have a positive antibody with a negative spec.
Joe, I'm not talking about antibody. I'm talking about antigen.
No, I agree with
if the mass spec is negative, done in a responsible laboratory like a Mayo Clinic, that excludes PLA2R induced disease 100%.
Okay.
All right. I have a feeling we haven't heard the end of this, but that's perfect for now. So,
I'm sure that Mario will have a reference posted.
oh, Mario's got he's got like the bat phone where you just pick it up and Helmet Rinky picks up the other side.
I have Fairbanks on the other line. Hold on.
I know, trust me. We're well aware of that. So
All right.
let's move along. Well, wait, leave it up. So, Casey, what would you do?
Well, I think OB is a good idea. I think that's probably going to be my first go-to. I mean, the KDIGO, the 2021 guidelines do say cyclophosphamide is the second line for Rituxan failed patients. I'm not sure. I mean, since the patient reconstituted, I think I would just go with OB as my first choice. I would keep the CNI on. I think that's probably doing something. I'm not sure if without it, maybe he would have albumin of 0.9 again. Maybe 1.9 is better than an albumin of 0.9. So I think I'll keep the CNI. I'll try to get OB. If I can't, then I'll add Cytoxan.
Dr. Reen, you had your hand up. I'm sorry, I missed it. You had something? You're muted.
You're muted. Dr. Reen, you're muted.
My comment was for Dr. Rubin's comment, because mass spectrometry is negative, then it is not PLA2 or positive disease.
Dr. Reen, how would you treat this patient?
Oh, Abdunazumab. I have used that drug with I was lucky to get in one patient, and it works like a charm. So
Is it easy to get in Canada?
If patient has private insurance, some of it will be covered by their private insurance, and the company backs it up with that. So we are able to get it if patient has a private insurance. It costs about $8,000 here, but we are able to get in some patients.
Arun, what would you do?
So I would favor changing to a cyclophosphamide-based protocol, because this is a high risk, very high risk, life-threatening nephrosis, and he's been on Ritux and a CNI, and agreed, we don't know what the antigen. I mean, but he's in a prolonged nephrosis. So at this point, I would talk to him about changing to a cyclophosphamide-based protocol. Although, because that's the only thing which has been studied. Ponticelli is the only regimen that's been studied in such high-risk patients with enough data. But I would also consider the rituximab with Cytoxan. But from an efficacy point, what is known is the Ponticelli. So I would talk to him about these two, but I would favor a Ponticelli.
Have you been able to get OB, Arun, in your practice?
We've gotten OB in some patients, but we have to demonstrate that they failed rituximab, like a severe allergy or something else. But out of the bat, for first line, I'm not able to get, Roger.
I was able to get OB once for a minimal change that had a pretty bad reaction to rituximab, but it took a lot to get it. And the other thing was that, OB is not supposed to have any cross-reactivity because it's a humanized antibody. And yet our allergy group that was working with the patient because she had this allergic reaction insisted upon desensitization before they gave her OB. And I don't know that there's ever been any. Well, our heme people claim that they have seen someone who had a rituximab reaction get an OB reaction this is in the heme disease, I don't know if that's ever been reported in renal disease. So I have used it once, but it took an act of God. I'm sorry.
Roger, catch Dr. Suki's post, which he just made, which is very observant. How about ofatumumab? Also a humanized antibody, also very effective in rituximab quotes resistant patients. And if obviously it's not labeled for membranous, there's nothing labeled for membranous, zero. But even cyclophosphamide is not approved. The only reason that insurance will pay for it is it's cheap.
It's interesting. I used ofatumumab once in a patient who also had a reaction. This was a long time ago. And there was something about it not even being produced or not available in the United States anymore, but somehow we got it, and we got it free of all things. But yeah, it's very similar to OB in that it's
Yes.
humanized and should be fine. So
Question, is there data, published data on the use of ofatumumab membranous?
Yes.
Yeah, there are some case reports. I thought mostly it works well in patients who are intolerant to rituximab, but not necessarily resistant to rituximab. That was my what I recall from when I looked into that.
there is a difference too that OB has a stronger, I mean, it has stronger
Yes.
tissue penetrance,
Yes.
for lack of a better way, and it has another mechanism, so it's faster. The depletion's faster, it's longer, and it gets more into the tissues, and maybe that's because we've all seen people that get rituximab and they have, they have CD19 depletion peripherally, but don't always respond, and then get OB and seem to respond. So it is a better drug for reasons I'm not sure we completely understand. Before we get
So Fernando Fervenza just answered me on this story with 100%. Let's see, he says it depends on the sample size of the biopsy, and if the biopsy is too small, which this one was not, you could have what Dr. Glassock said. So I am not buying the Canadian nor the California approach to this, but I'll update the group on what I find.
We'll wait for the updates. One last thing, since we've moved on to treatment, though, is that remember in the Mentor trial, if you did not have a complete response at 6 months, you got redosed with another 2 grams of rituximab. Okay, that wasn't done here, but I'm just saying, I'm not, and there was a response initially, at least with the partial, to B cell depletion with rituximab. So in a world where you couldn't get OB, maybe Rituxan, could still have a role here. I'm not saying, I'm not really sure there's a Rituxan failure.
And that's what Dick's point was. That's exactly what Dick's point was, because we don't know what we're measuring. And if this were PLA2R, the PLA2R could have come way down, and it still may lag the proteinuria for another 6 months. So, unfortunately, we don't have that. So we tend to feel that it's more likely to be a failure when it may not be.
So, quick point, Bill. In the Mentor, I know that they redosed in 6 months, but they redosed only if the patient underwent partial remission. This patient is not in partial remission.
Yes, he is. It was if he does not achieve complete remission, they redosed. So if there was any proteinuria that was persistent at 6 months, they redosed.
I think it was only partial remission because if it failed, then they exited from the study. So if this patient has not attained partial remission, then the Mentor did not redose at 6 months.
Well, I mean, his proteinuria was cut in half before they started tacrolimus, and then it went back up.
Well,
I mean, that's a partial remission.
we got two fights going on here: Whittier versus Brune, and Mario versus Dick.
I'm happy acquiescing.
Well, we'll figure all that out later. I want to go over a few of these possibilities just to show you what the literature is on psoriasis, non-steroidals, and GLP-1.
A small point, Roger, that Fernando and I have just written a paper about this, so I'll give you a little advance notice. In patients who have massive proteinuria, profound hypoalbuminemia, a substantial amount of rituximab is in the urine. 2 grams of rituximab is inadequate treatment for such a patient. A patient like this should have gotten 4 doses of rituximab initially, not 2, because half of the stuff that you gave. Now, the fact that you got a 0 B cell number is encouraging, but you don't know what happened to it in 2 weeks or 3 weeks. You'd have to do serial measurement because the suppression may have been very short-lived. So the complicating story here is maybe he didn't really get enough rituximab to show a response, and you have no anti-PLA2R to monitor it. You're poisoned by the fact that the only parameter you can follow is proteinuria, which isn't very good. I don't disagree with pulling the trigger on cyclosporin or a CNI. This guy is at high risk and he has to take anticoagulant. You want to get his proteinuria and his serum albumin up as quickly as possible. and a CNI probably is reasonable, but it's not good long-term treatment. It's very poor.
Yeah, I
And
think
that's
here it
been
was just,
shown in numerous trials.
here I think it was just an adjunctive for
It
helping.
was a bridge, a
It was a bridge,
bridging.
yeah. So
Yeah.
Dick, let's just, I know that you would rather use OB, but let's say you don't have OB available. Would you give 4 grams of rituximab at 6 months? Or would you give what would you do, Ponticelli or Niles?
If OB is not available, I would give him 2 more doses of rituximab now, maybe 3. His proteinuria is better, so maybe he won't lose enough in the urine. I don't see any reason to jump in with cyclophosphamide at this point. His serum albumin is coming up. His renal function is stable. His proteinuria is down by 50%. There's no.
Yeah, I don't know. I'm not so sure that the albumin's up that much and the proteinuria is down that much, but
Proteinuria went from
it went
14.
from 1 to 2.5, didn't it?
Yeah, the proteinuria went from 14 grams and it's back. It went down to 4.5 grams, and that was after I started the tacro.
it went
And
back
now
to
we're
10.
6 months out, and he's on the tacro, and it's back up to 10 grams. So
And
it's
the
actually
albumin
gone from
never
14.
got above 2.
The albumin has not gone above 2. No.
It was 1.8.
Okay.
Yeah, so.
All right.
Looking at this slide here, it's just when you look at all the different causes of membranous, I just can't believe this list, how long it is. Fortunately, Mayo has worked out a lot of these. Almost all this work was done by Sethi and Provenza at the Mayo Clinic, and I think we'll see this grow. This was 2025. The next version of this will probably have more antigens in it. But it's incredible growth since PLA2R was first described by Dr. Salant, I don't know how many years ago now, maybe 10, 15 years ago. Okay, so this is membranous that has been associated with psoriasis. It tends to be psoriasis vulgaris, which brings up the interesting point of the possibility of mercury-containing creams. Because look when this was presented, or when this was published in 1996. I mean, who knows what was going on at that point? And I think Dick's point, it's very possible that maybe we were dealing with a lot of NEL before we knew anything about this, that this could have been. I like that thought a lot because it's a very old report. This is a more recent report that looks at 2016, which looked at PLA2R in patients with psoriasis. And the majority of them are PLA2R negative. Our patient is PLR2R negative. But some of them were PLR2R positive. And who knows if this is then that perhaps their psoriasis is just a coincidence. Maybe it's a coincidence in all of them. I don't know. It's hard to say. Psoriasis is not a rare disease, but I don't think so. I think there's enough cases out there. It's probably related, but I think more often than not, it's PLA2R negative. I remember when this came out in the late 90s, talking about nonsteroidals, and then all I could think of was, everybody takes nonsteroidals. It's got to be a coincidence, and I wasn't very convinced that there was a disease, and I really wasn't convinced, to be honest, until the antibody was identified by Mayo in the last couple of years. But what's interesting about this is that if you look at the left there, only 3 of them were on ibuprofen. I think that the other, and when you consider how many people take ibuprofen, my impression is that ibuprofen is not as membranous-ogenic, if I can use that word. A lot of proteinuria in the second column here. Most of the patients did not get treated, and most, probably the best argument that it was non-steroidal related is that a lot of them went into remission just being off the drug, although some took quite a while, up to 60 weeks, with a fair amount of follow-up. So, I really wasn't sure, but, here's yet another case of a patient that got it twice, got ibuprofen the first time, or naproxen the first time, and piroxicam the second time, and, immediately went away. Was stopping the naproxen in the first, and then second case, it went away but came back and eventually required therapy, initially with a CNI, steroids and cyclosporin, and really didn't go into remission here until the patient got cyclophosphamide. So it's hard to say if this was really the second one was membranous related. You would think, I mean, we're talking about an awful long time before the patient went into remission. But it's certainly the first one argues that it was. It's kind of an interesting case. And then finally, you know, I think as was mentioned, the PCSK6 as the antigen target is now pretty well established, but both by the Mayo Clinic and Arcana, that a majority of the patients that have this antigen have also had a very strong history of exposure to non-steroidals, and actually for quite a while, you know, in the upper over 2 years in the one, which is kind of interesting. It's not like a you know, a rapid idiopathic response that we sometimes see. This is the one, you know, Bill hadn't even heard of it. I've barely heard much about this. Of course, it was somebody brought it up immediately in the chat. Podocytopathy associated with semaglutide, and this may be the new membranous. You know, my opinion before was everybody's on membranous, everybody's on non-steroidals. Well, everybody, you know, is now going to be on a GLP-1, and so this was 3 cases that Kanar published in AIM clinical cases, and 2 of the 3 had anti-nephrin antibodies, which is interesting. And now, who knows? You know, he has very strong ability to do that staining, and I think Astrid was one of the Dr. Wiens was one of the first pathologists that described the dusting. So he's able to pick this up probably better than most people. But
correction, was not Astrid, was Helmet Renke.
Wasn't she there at the time?
Well, she was, but the one that brought this to fact was Helmut with his diligent observation, and then Astrid picked up on it.
Yeah.
All right. Well, next slide. And then I can advance it. Sorry. And then he had actually a 4th case in another report, and this 4th one also had the fine dusting. So I think there's probably the real thing here, and that GLP-1s, and it's something they were going to have to think about. You know, a few years ago we had to start thinking about how COVID was related to all, you know, resurgence or the beginning of certain glomerulopathies, and this may be the new COVID-related, you know, infection or drug-related GN with GLP-1. And of course, you know, anybody can make a cartoon, and I don't mean to insult anybody, but you know, somehow it stimulates an antigen-antibody complex and maybe a second hit in a genetically programmed individual. But it'll be interesting to see how this plays out, since these drugs are so commonly used now.
Just because I don't know, Roger, with GLP-1 cessation, did the minimal change go away, or did they all get treated with steroids, or do we know?
They all got treated here in Kanar's group, so I don't know if they would have, how long if they would have waited, if it would have gone away or not.
Right. Thank you.
Yeah. So, you know, we came up, you know, we had this poll here, and, you know, what about the options here? I'll very quickly go over this, but, you know, as far as our cyclo trial didn't really show that from a timing standpoint, that rituximab was any faster than, this is all comers, than a cyclophosphamide, or slower than a cyclophosphamide. It's certainly, cyclophosphamide's a better drug in patients with PLA2R membranous who have high PLA2R antibody levels. I think that would be the preferred. Anybody feel free to correct if I'm wrong, but I think there's evidence that if you have a very high PLA2R, that perhaps start with a cyclophosphamide based protocol. But there really isn't any difference here, but that isn't really what's, you know, what we're talking about here, because this is really more perhaps failure. I don't know. This is the Niles protocol that we've talked about. We've shown it many times. The thing, this gets a lot of press. What's really interesting about it, though, is it's non-controlled. He just reports, you know, all these patients. It was a long time ago, so we only know PLA2R was available for 5, 4 of which were positive, but we don't know exactly how many were. But you can see, I mean, if you look at, even though it's a report of non-controlled, they have a very good response rate. Partial remission 100%, complete remission almost 100%, probably only 1 patient. And they do it pretty quickly. You know, they have a pretty fast response rate, especially, I think it's here. Yeah, well, maybe not.
Could you go back to that slide, Roger, because I do want to.
Yes, please, Dick.
There's no evidence that this pattern of response is cyclophosphamide dependent. if you look at the protocol, these patients received very large doses of rituximab. We don't know. There's never been a controlled trial, so we really shouldn't attribute this so-called response as a cyclophosphamide-dependent response. Maybe it is, but we don't
Well, I
really
think
know.
that's fair, and I think that and when you look at the safety of rituximab versus cyclophosphamide, I mean, my general feeling has always been, oh, it's a safe drug, and cyclophosphamide is so dangerous, and that's not really the case either. When you look at the data, there's not that much difference in safety. But I think we have that. I'll speak for myself. We have that gut feeling that, oh, I can just give rituximab; it'll be easier and safer, and so I think people get very biased for that, and I'll wait for cyclophosphamide till something fails. But I think Dick's point's well made. Casey brought this up that KDIGO says if you don't respond to rituximab, the next is to go to cyclophosphamide. What is non-response is up for grabs and would have to do with the antibody and what you have and if you can measure it, et cetera. Hopefully, it'd be great if someday we can measure all these and we can use an antibody level like we do for PLA2R, because that's really what Dick was pointing out. You treat the antibody. You treat the antibody, and you'll get your response if you can hang in there. So this is really what we're talking about in this case. Although, granted, maybe this is not refractory, but we're going to go ahead with this, that it's refractory membranous. 18 patients who failed a prior course of immunosuppression, 14 of which were PLA2R antibody positive. They gave 1 gram OB at 2 weeks, and if not CD19 depleted, they gave a 2nd gram of OB, which would kind of go against Dick's bias that we have to be careful not to undertreat because we lose it all in the urine. And I don't think there's any reason to believe that OB would go less in the urine than rituximab. All of them went into remission. Meantime, time to remission, 2.7 months is pretty impressive. Pretty impressive data. And Dick was mentioning this study that's, was that published, Dick?
What?
The OB study.
No, the Majesty trial is only a press release. It isn't actually published yet.
Good. Well, we'll look forward to that.
The other thing about obinutuzumab that you touched on, Roger, but I will underscore what you said, is that rituximab mainly affects the B cells that are circulating, while obinutuzumab has tissue effect as well.
Yeah.
I mean, it's a much more potent agent in that regard.
It may be more potent too. It may last longer. It may get in the tissues and have an effect. Yeah, but I'm sure in the future we're going to learn a lot more about that. Just realize that, that 66% of these patients had 2/3 had received rituximab prior to receiving the OB.
This paper you just cited, I think, is not a very good paper. Probably shouldn't have been published because they didn't do serial PLA2R antibody levels. And you cannot define refractory membranous if you don't know what's happening to the anti-PLA2R antibody. They were basing refractoriness on the proteinuria, which is the lousy endpoint.
Can I ask David a question? David?
He may be off. He often has to go.
I was just curious whether or not complement was present by IF.
Good point.
Well, before Dr. Glassick trashed this paper, you can see
well,
that.
I didn't. I'm just pointing out that
you trashed it.
If you're reading the literature and the title says refractory membranous,
okay, well, here we have some
your antenna should be way up that this paper isn't really addressing the issue of refractory membranous.
I love the fire today. There is fire.
This is a new low for us, or a new high. What are the two? So here we actually have the response based on PLA2R. So PLA2 had a faster response. I don't know if they have the levels, as Dick said, but it did have a faster response than PLA2R negative. And this would, if our patient is refractory, this would be our patient, would not have as expected a rapid response. And most of these patients were PLA2 positive. So if you do go with OB Previr, you might even have to hang in there even longer. And then I'll just move on. But so for lack of time or for the sake of time, so the real unanswered questions we have for non-PLA2R membranous, which I think this case brings up, is as Dick brought up very early, since you don't have a serologic marker, how long do you wait until you assume treatment failure? That was brought up in the first 10 minutes of this case. If and when this is considered treatment failure, what is the preferred option? Patients, Dick brought up the possibility, just hang in there, or perhaps we aren't giving enough rituximab. Go to cyclophosphamide, or rituximab. OB, I do think that OB will be replacing rituximab for just about everything we use rituximab for the reasons I brought up and Mario just brought up as well. And there is some literature on even Velcade or Dara for absolutely refractory, totally refractory membranous when you're at a complete loss. But I think that in a couple of years, it won't be the Mentor trial; it'll be the Majesty trial that we'll be talking. I hope so, and I hope we can get it, and I hope that Dr. Whittier can get it on formulary at Rush. He's head of the pharmacy committee at Rush. We are 12 minutes into 2 o'clock. I want any other comments on anybody?
I'm glad everyone was.
I want to ask Pravir, what are you going to do, Pravir?
Well, this is exactly where I am. I think, ideally, based on everything I saw, I have two options. I would either, if I can get obinutuzumab, wonderful. I think I just have another patient I am trying to get, so maybe I'll push my luck and have two of them. But otherwise, I think doing rituximab again, 1 gram times 2, instead of just a one-time dose, may be the way to go. And so I'm kind of leaning towards that. But I'm glad everyone else is as interested as I was, because this is kind of where we are with this guy. And there were some other questions on there. IgG4 workup. No, it's a great question. I mean, IgG4 would be very steroid responsive, but also should respond to rituximab. So I didn't do more work up there. And in terms of anticoagulation, yes, I know like heparin, low molecular weight heparin or Coumadin, warfarin have been studied more. However, given his also BMI, I wasn't a fan of Lovenox, and I didn't want to check INR, so I have him on Eliquis.
Now, you're dealing with an immune complex disease here, clearly. The antibody has not been found. Now, as I mentioned in passing, let's say that the IF was positive for complement as well. Would you consider an anti-complement agent in addition to either obinutuzumab or Ritux?
Not yet, but I think that would be the back. I think then I'm just adding a lot of stuff, and every time we do these things, you're adding risk with this patient. But I think I wouldn't add it on. I don't know if I don't think we have any studies with that in this particular disease. I would probably just do it solo therapy. If nothing is working, maybe last ditch. But at that point, if it's not working, I'll go to cyclophosphamide before I do that.
So Casey brings up an interesting point that if you don't mind, Casey, that we see severe proteinuria and minimal change disease, yet we don't see the effect of rituximab wasting, or we don't think we do. Maybe if it's selective proteinuria, we don't waste as much rituximab. Maybe it's more albuminary and you don't lose as much rituximab is one possibility. Dick, you have your hand up?
No.
Okay. There's one other hand up. I have to see if I can see who it is. I think that's it. Well, I think we're going to move on. So, Pravir, I would just suggest, I went through hematology at Rush, and they were able to get the OB for me. And I would not try with RUM. They're a little more strict on their protocols. So
why not use rituximab again plus MMF, because it behaves like an anti-nephrin type of disease. If we postulate it was GLP-2 induced disease. So because they generally tend to relapse, if you add Salcept along with rituximab, that may work out if you don't get OB.
Yeah.
Now, Fervenza just answered, and he said, when are you going to listen to Glassock and stop it? I mean, he said, if mass spec is negative and ELISA is negative, it's negative. Finish it. I'm just paraphrasing to add some more color to it.
Well, happy birthday, Dick.
Thank you all.
Okay. All right. Well, see everybody next time. Until then, stay safe. Thanks, everybody.